Good afternoon to everyone that you just joined. In this webinar, we will be talking about the outpatient prospective payment system and the physician fee schedule final rules, which would take effect in January of 2023. My name is Susana Molina, and the webinar will be hosted by the Adventist Health Policy Association, which is the policy voice for the 5 7-day Adventist affiliated health systems in the United States, including Advent Health, Adventist Healthcare, Loma Linda University, Veteran Health Network, and Adventist Health. And today you will be hearing from our team, which includes myself, Sherry Danielson, Marisa Lopez, and Brandon Cook. We will be covering key policies in the OPPS and PFS final rules. As a reminder, OPPS sets the payments for outpatient services, and the PFS rule sets payments for clinicians. The rule also includes updates to various quality programs, and most of the policies, as I mentioned earlier, with a few exceptions, will take effect in January of next year. And here are the key highlights in the OPPS rule. CMS removed 11 services from the IPO list, allowing them to be done in both the inpatient and the outpatient settings. At the same time, 8 new services are being added to the inpatient-only list that were recently created by the AMA editorial panel. So these are new CPT codes. Cherie has a link in her slides to all the final CPT codes and the changes to the inpatient-only list. The rule also finalized the adoption of prior authorization for a new service line, but delayed the effective date until July 1st, which was a positive change compared to the proposed rule. For the 340B program, CMS will go back to the higher rate of ASP plus 6% beginning in January of next year. However, CMS did not finalize a methodology for making hospitals whole. That will be determined in a rule to be released next year. CMS also finalized changes related to the newly created rural emergency hospital designation. They also adopted new policies to expand behavioral health. I would say that the most important policy to note is that CMS will be permanently reimbursing for mental telehealth services provided in a patient's home. As you all know, this was a flexibility that was adopted for the public health emergency. So we're happy that CMS will now provide coverage for outpatient behavioral health services provided in a patient's home. And then to facilitate this permanent payment, CMS has created these new codes that you're seeing on your screen. And finally, CMS is also increasing access to care by further extending the supervision authority to non-physician practitioners for select diagnostic services. This was a flexibility that was awarded during the public health emergency, and now CMS has also decided to make permanent. And this is an overview of all the issues that our team will be covering on the OPPS rule. In regards to payments, CMS finalized an increase of 3.8% to the outpatient payments. This was a positive change, as in the OPPS or proposed rule, they had proposed only increasing it by 2.7%. And the same is true for payments to ambulatory surgical centers. Those were also increased by 3.8%. And now moving on to rural emergency hospitals, which is a new designation that was created by Congress. CMS created this new designation in 2021 to help rural hospitals financially. This designation is only available to hospitals that have less than 50 beds, and whichever hospital decides to convert to a rural emergency hospital, they have to stop providing inpatient services. So any length of stay for patients seen at these hospitals cannot exceed 24 hours. These hospitals also would need a state license to be able to operate. and all states may not yet have a state license available for this designation. Those hospitals that are eligible for the rural emergency hospital designation will receive an additional 5% OPPS payment for their outpatient services monthly, which is about a $268,000 facility fee. To become a rural emergency hospitals, entities must submit a form called the CMS 8555A to change the enrollment application. So they wouldn't be enrolling as new hospital, they would just need to file a change of enrollment. We raised in our comments that we were not clear whether these hospitals would be eligible for the 340B discounts. CMS did not provide a response, unfortunately, in the rule. They did say that HRSA had jurisdiction over this issue, over whether these entities would be eligible or not for the 340B discounts. For the discarded single-use dose policies, CMS created, actually Congress passed a law last year that requires manufacturers to provide a refund to CMS for certain discarded amounts of single-use packaged drugs. So this is only applying to single-use packaged drugs. In order for CMS to be able to collect those refunds from manufacturers, they need to be able to know how much our hospitals, or how much of the amount of drugs is actually being discarded. Although there's currently a modifier for attesting to how much of a drug is discarded, CMS believes that that JEE modifier is not being used as it should be, that maybe some hospitals are forgetting to use it. So they have finalized the creation of a new modifier called the JC modifier that all outpatient facilities should start using beginning on July 1st. So beginning on July 1st, facilities must use the JW modifier to attest any amounts that were discarded, and the JC modifier to attest that no amount of that drug was discarded.
Now moving on to the 340B drug program. As a quick summary of what has happened with the 340B program so far, in 2017, CMS cut payment rates for 340B drugs by almost 30%. This caused several hospitals, including some AHPA member hospitals, to file lawsuits to stop these payment reduction. The Supreme Court ultimately sided with the hospitals and agreed that CMS acted outside its statutory authority. Now HHS is reversing these payment cuts through the OPPS final rule. While CMS is restoring 340B drugs to the original payment rate for 2023, it is applying a 3.09% reduction to the OPPS conversion factor to stay budget neutral. While the finalized reduction is lower than what was originally proposed, there will still be cuts across board to non-drug services as a result of restoring the payment cuts. CMS also stated that it will issue a separate proposed rule to address how they will remedy the cuts made between 2018 and 2022. That rule should come out before next year's OPPS rule.
And now we're going to take a look at some changes to prior authorization. In 2020, CMS adopted a prior authorization process as a condition of payment for hospital-based outpatient services. The goal of prior authorization is to control unnecessary increases in volume. For a full list of services that are subject to prior authorization, you can see table 103 of the final rule, or reach out to our team and we can send you a link that will take you right to it. CMS will add one new service category, facet joint interventions, to the prior authorization list beginning in 2023. This new category is made up of facet joint interventions, nerve destruction, and medial branch nerve blocks, and includes the CPT codes that you see listed on the slide. Now we're also going to look at telebehavioral health. As Susanna mentioned at the top of the presentation, CMS is now going to cover behavioral health care delivered via telehealth to beneficiaries at their homes. During the public health emergency, CMS allowed flexibilities for providers to be reimbursed for providing these telehealth services to patients at home, but these were originally slated to end with the end of the public health emergency. The agency was concerned that requiring only in-person treatment would have a negative impact on patients' access to care, particularly for those of our patients who live in rural areas. This is an area where AHPA heavily advocated for the preservation of these flexibilities, and we are happy to report that after further consideration, CMS will finalize that proposal by creating 3 new HCPCS codes that will cover behavioral health care for beneficiaries, even when they are at home. The inpatient only and ambulatory surgical center lists are used by CMS to regulate the site of service for various healthcare procedures. Inclusion or omission is determined by many factors, including patient safety, quality of care, and cost. If a procedure is on the inpatient only list, it means that it is only reimbursable if it is performed in the inpatient setting. If a procedure is on the ambulatory surgical center or ASC list, it means that it could be performed at an ASC to reduce cost, or it can also be performed inpatient. CMS originally proposed to remove 10 services from the IPO list in 2023. Although originally proposed for removal, CMS has elected to retain 16036 on the IPO list. And after advocacy from a subset of clinical trade organizations, the agency has decided to remove 2 more services from the IPO list. This really highlights a recent trend that we've been seeing from CMS of being fairly responsive to well-reasoned and well-articulated advocacy, even when they have an idea fairly baked or when only a small group of clinicians are raising particularly a patient safety concern. And then again, just as a reminder, the IPO list is CMS's way of saying, hold on, the only way that this can be done safely is in the inpatient setting. So when these items are removed, it means that they now believe that they can be done safely either inpatient or outpatient. After patient safety review, CMS is also going to add 8 of the newly created CPT codes to the IPO list. This is effective January 1st. And for a full list of all changes to the IPO list, you can see table 65 of the final rule.
Now moving on to the physician fee schedule rule. These are some of the key highlights that were covered in the rule. CMS finalized the addition of 5 new MVPs for clinicians to choose from. And then multi-specialty groups will be required to participate as subgroups when reporting MVPs, but that change will only apply beginning in calendar year 2026. CMS also finalized all the changes pertaining to the MSSP program as originally proposed. They also added new improvement activities related on health equity. As you all know, CMS is weaving health equity into all the quality programs, and they are designating those new improvement activities on health equity as high priority measures, meaning that they are highly weighted. For telehealth, CMS is reminding all stakeholders that they're extending the flexibilities for 151 days after the public health emergency ends, which, by the way, CMS, the White House has not provided yet a 60-day notice notifying stakeholders of the end of the public health emergency. So we know that it is going to be renewed in January. What we're hearing is that most likely it will expire in April of next year, but there is no warranty on that yet. CMS is also adding 53 new Category 3 services to their temporarily covered list. These services have nothing to do with a public health emergency, and as will be covered later on, they will only be reimbursed until the end of calendar year 2023. CMS also added new permanent codes for prolonged services, and they're delaying the in-person requirement for behavioral health services provided via telehealth until 152 days after the public health emergency expires. And the reason for that is because this new policy is not related to the public health emergency. It was actually finalized in the Consolidated Appropriations Act. CMS is also finalizing several policies seeking to increase access to behavioral health. First is allowing our auxiliary clinicians to provide services under general rather than direct supervision, providing more flexibility. And then they're also creating a new G code to reimburse for behavioral health integration performed by clinical psychologists or clinical social workers. These are all the issues that we'll be covering in today's PFS presentation. CMS finalized its proposal to reduce the conversion factor from 34 to 33 in calendar year 2023. The reason for this decrease in the conversion factor is because that 3% payment adjustment that Congress provided last year is expiring by the end of this year. Most specialties will also see an estimated positive or negative 2% payment adjustment that is unrelated to this conversion factor. And this is actually table 148 from the rule. This is the impact, the combined impact to all the specialties. As you can see here, there are a couple that have max 2% adjustment, where some, like diagnostic testing facilities, those are going to receive a 7% estimated positive adjustment. Same thing here. The highest payment decrease is 3%, and then not a lot of positives, unfortunately. We do know that Congress is interested in mitigating these payment reductions related to the conversion factor. A bill introduced in the House has set the negotiations, that's HR 8800. Which would completely eliminate the payment reductions included in the rule. However, that is very unlikely to happen. What we are hearing is that Congress plans to reduce the payment reductions, potentially giving a 2.5% boost as opposed to the 3% that Congress gave last year. In fact, there was a letter signed by 46 senators that was sent out to congressional leadership on November 2nd, encouraging congressional leadership to mitigate this payment cut. So we know that action is probably going to be likely on this issue.
CMS is also finalizing some changes to their quality payment program. The quality payment program seeks to reward high-value care through the merit-based incentive payment system, what we call MIPS, as well as advanced alternative payment models, or APMs. The merit-based incentive payment system is one of two tracks housed within the QPP. Its goal is to migrate Medicare Part B providers over into a performance-based payment system. Opting into MIPS comes with data reporting requirements, performance feedback, and a MIPS payment adjustment based on performance. Participant performance in MIPS is measured across 4 domains: promoting interoperability, quality, improvement activities, and cost. This year, CMS finalized no changes to the weights across these domains, although the quality domain will now have a health equity adjustment that will bump up scores for those serving underserved communities and will guide CMS's extension of exceptions for extreme or uncontrollable circumstances. Health equity measures will also now be considered a high priority. CMS has added 5 new MVPs, or MIPS value pathways, for reporting in 2023. And these are a subset of measures and activities that can be used to meet MIPS reporting requirements and are the agency's ultimate goal for participation. The 5 MVPs that you see on the screen are now for reporting in 2023 and will join the 7 already existing MVPs that were finalized in last year's rule. There are also some final changes to the MIPS Promoting Interoperability program. For those of you who joined us for our webinars on IPPS, this will look extremely familiar because CMS is mirroring the changes in the Promoting Interoperability programs across all of the different payment rules. So this is exactly the same. For example, they'll require, you see highlighted in green first, the query of the PDMP measure under e-prescribing. That is now going to be mandatory with a potential 10 points that can be picked up there. Under the Health Information Exchange objective, they have also added the enabling exchange under the Trusted Exchange Framework or Common Agreement, TEFCA, as an option. This would require a yes/no attestation. Promoting interoperability scores are still out of 100 points with the opportunity to earn bonus points in the data exchange objective. Beginning in 2023, clinicians and groups that are participating in APMs will be allowed to participate in PI-related reporting at the entity level.
Okay, so moving on to the Medicare Shared Savings Program. For an overview, this is a voluntary alternative payment model that gives providers the opportunity to create an accountable care organization or ACO and earn bonuses through shared savings. CMS finalized many of their MSSP proposals as proposed. They believe these policies will be a step in the right direction to reverse concerning trends in the program, like a plateauing effect in the number of beneficiaries assigned to ACOs, an underrepresentation of higher spending populations, and an inequitable distribution of participants based on their racial backgrounds. On this slide, you'll see the major proposals we're going to dive into. CMS anticipates that the shared saving program policy changes will increase participation, particularly from ACOs serving beneficiaries with greater needs and higher baseline spending, and that the incentives for ACOs to reduce spending over multiple agreement periods will have a net positive on the program. This will be a high-level overview of the changes to the program. If you would like more information over the MSSP, please feel free to send us an email. Up first, we have the advanced investment payments, which were finalized as proposed. Starting in performance year 2024, eligible ACOs can receive a one-time fixed payment of $250,000 and 8 quarterly payments based on the needs of their beneficiaries, which is calculated on the number of assigned beneficiaries and then adjusted by a risk-based score, that being based on beneficiary dual eligibility or the New Area Deprivation Index, the ADI. To be eligible, ACOs must be new, so not re-entering or renewing, must qualify as low revenue, and must be eligible to participate in the MSSP and be inexperienced with performance-based risk. CMS is planning on recouping the advanced investment payments from shared savings earned by an ACO. However, if an ACO does not achieve savings, the recoupment will carry over to the next year. CMS received support for the adoption of the AIPs. However, many commenters, including AHPA, requested that CMS expand eligibility to existing ACOs as it would benefit underserved beneficiaries and work to combat health inequities. CMS acknowledged this request, but stated that the AIP is intended to help provide an ACO with startup funding needed prior to earning shared savings, not for providing indefinite support to ACOs. One comment from MedPAC supported the proposal and the approach, but cautioned that the impact of the AIP may not be the same as in other models. CMS responded that it would continue to evaluate the impact of AIPs to ensure the program improves quality and does not result in additional program expenses. AHPA is happy to see the adoption of AIPs. However, we believe that ACOs that receive this funding need to be diligent in their record keeping with a keen focus on how the AIPs improve their ability to operate, as this will be important information to share with CMS in the future. Next, we have the transition to performance-based risk. CMS finalized the proposal to alter the pathway to success model, which sets a very concrete roadmap for ACOs to transition to two-sided risk within 2 years of joining the program. Beginning in 2024, CMS will allow ACOs that are, at present, participating in one-sided risk to remain at their current level for the remainder of their agreement. Additionally, new ACOs that are inexperienced with risk or are entering into the program for their first agreement will be allowed to stay at level A risk for the entire 5 years of their agreement period. CMS will also permit ACOs to participate in the basic track glide path for a maximum of 2 agreement periods, beginning at level A for the first agreement and then progressing into the glide path for the second agreement, meaning that new ACOs could receive the first 5 years at no risk and then the first 2 years of the second agreement at no risk. Lastly, if an ACO is entering into the program at level E, they will be able to remain there indefinitely. For the quality reporting requirements, CMS finalized its proposal to fully transition to eCQM reporting and do away with the web interface by switching to only APP reporting mechanisms beginning in performance year 2025. CMS also finalized a new alternative quality performance standard beginning with performance year 2023 for the purpose of applying sliding scales to shared savings and losses. An ACO achieving a quality performance score equivalent to or higher than the 10th percentile of the performance benchmark and at least one of the 4 outcome measures in the APP measure set would be eligible for shared savings. Looking at the health equity adjustment, CMS will be incorporating this into the shared saving program beginning in performance year 2023. The adjustment will be applied in the form of bonus points added to each ACO's MIPS quality performance category score to generate its health equity adjusted quality performance score. To be eligible for the health equity adjustment, ACOs will need to report 3 eCQMs, meet the completeness requirements, and fill the CCAPS for MIPS survey. AHPA and many other commenters supported the concept of a health equity adjustment, but raised concerns that the requirement to report 3 eCQMs will limit participation. CMS disagreed with this feedback and believes that the finalized policy will appropriately reach the targeted audience. To further incentivize participation in the program, CMS finalized its proposal to apply a new approach to low revenue ACOs to help qualify them for partial shared savings. Beginning in January of 2024, new, renewing, and re-entering ACOs at any level of the basic track that satisfy the eligibility criteria do not meet the minimum savings rate requirement, but do meet the quality performance standard would qualify for partial shared savings. CMS finalized revisions to the benchmark with the goal of improving sustainability. This included a modification to the existing methodology to remove the negative regional impact. Important to note that the positive regional adjustment will remain. This change will allow ACOs with higher than average historical spending to have a benchmark calculated solely using their historical experience. Additionally, CMS will be incorporating a prior savings adjustment and the historical benchmark for renewing and re-entering ACOs. CMS believes this will help mitigate what is called the ratcheting effect, which means when an ACO enters into an agreement and successfully reduces utilization, and then the ACO renews their baseline years or their previous performance years, it can make participation in the program harder, especially if utilization was greatly reduced. And lastly, for the MSSP portion, CMS finalized proposals to reduce the administrative burden in the program, including eliminating the need for an ACO to submit marketing material to CMS for review, reducing the frequency of notices from annual to once per an agreement period, and streamlining the process for requesting a waiver to the SNF 3-day rule. Again, this is a lot of information over the MSSP program, so if you have any questions, please feel free to send us an email. Looking at the split or shared EM, one change here we wanted to note, in the past rule for 2022, CMS finalized a policy where the physician or NPP who performed the substantive portion of a visit will be responsible for billing. They defined the substantive portion to mean more than half of the time. In this year's rule, CMS will delay the implementation of the definition of substantive portion until 2024. It's worth mentioning that CMS still believes that the definition of substantive portion is appropriate. However, CMS noted that the delay will allow for providers to get accustomed to the new coding and payment changes. For telehealth, CMS will be adding services to the Medicare's telehealth service list on a Category 3 basis. These services were previously included on the telehealth list on a temporary basis during the public health emergency. But like Susanna mentioned earlier, we're expecting the public health emergency to be expended in January and then expire in April. And with the services going on the Category 3 list, they will be extended through the end of calendar year 2023. Many commenters, including AHPA, supported the inclusion of the additional services, but expressed concern about the practicality of including these services given that the Category 3 list is set to expire. Additionally, many commenters believe that the these codes should be permanently added on a Category 1 or Category 2 basis, as they have been shown to produce the same quality of care as in-person visits. CMS noted these concerns and encouraged interested parties to use the extended time to gather data on the use of these services.
Now moving on to behavioral health services. CMS is finalizing its proposal to allow behavioral health services to be provided under general supervision as opposed to direct supervision of a physician or NPP when these services are being provided from auxiliary personnel such as a licensed professional counselor or licensed marriage and family therapist. This policy is one of the ways CMS is addressing the shortage of behavioral health providers. CMS has also been creating new codes for behavioral health services for the past few years. Last year, they implemented codes to expand telehealth for behavioral health care. This year, CMS is finalizing their proposal to create a new code for services furnished under the psychiatric collaborative care model, which aims to integrate behavioral health and general medical services. This code would account for mental health services furnished by a clinical psychologist or clinical social worker in an integrated care setting. Behavioral health continues to be a huge bipartisan priority, and we expect policymakers continue to not only tackle it through regulatory means, but through legislative efforts as well. There have been several mental health packages that have been introduced in the House looking to reform and expand behavioral health services. The Senate Finance Committee has also released a bill that aims to reauthorize multiple mental health programs through 2027. These bills are currently being negotiated as part of a year-end package. There is a possibility that mental health reforms will be punted to next year, but we still expect that next year's Congress will address behavioral health. The results of the midterm elections gave us a split Congress. While there are some fears about gridlock, historically, a split Congress is actually able to pass more legislation than one controlled by one party. This is because the legislators will be forced to work across the aisle if they want to be able to go back to their voters and show that they were able to achieve something. While partisan priorities will likely not be able to pass, Congress members will focus on bipartisan initiatives, and behavioral health is a huge bipartisan priority. So we expect to it being one of the main focuses of next year's Congress. Finally, we'll cover the finalized proposals addressing opioid treatment programs. CMS is working to strengthen their OPTs by providing more flexibility in furnishing services. CMS is finalizing the OPT intake add-on code to include a two-way audio-video call. CMS is also increasing the time for a base rate of individual therapy to 45 minutes. CMS is choosing to do so because they are recognizing that some therapy visits take longer than the current 30-minute time frame, particularly during medication-assisted treatments or other treatments for opioid use disorders. And finally, CMS is updating the methodology for pricing the drug component of the methadone weekly bundle and add-on codes for take-home supplies. Methadone is a drug used to treat chronic pain or opioid dependence. The old method-based payment rates on the average sales price with the inclusion of newly reported methadone tablets caused significant decreases in average sales price. Therefore, CMS is finalizing that the drug component of the HCPCS codes will be based on the payment amount for methadone in 2021 and updated annually to account for inflation. This would prevent the payment rates for methadone to fall. And that concludes the finalized policies for this year's PFS final rule. If you have any questions, now is the time to unmute your lines or enter your questions in the chat box. And it looks like we had one question from Todd Gable. Will JZ apply to all drugs or just those with pass-through payments like the JW is today? And Susanna did respond to him. Susanna, would you like to answer that question?
Sure, thanks, Maris, and thanks, Todd, for the question. So CMS in the rule didn't really specify if it only applied to those drugs where are applicable to pass-through payments, but they did have those specific exclusions. So radiopharmaceuticals, imaging agents, drugs requiring filtration, and those new to Medicare Part B reimbursement. Those were the only exclusions that they mentioned in the rule. Any other questions? All right, well, thank you everyone for joining this webinar. We will be providing the copy of the presentation and the recording this week, and also included in the policy brief newsletter that our team distributes on a bi-weekly basis. If you have any questions, please feel free to reach out to us, and we'll be glad to provide any additional information. Thank you.